Hello, my name is Naomi, and today I'm going to talk to you about my reflection on the reading this week. And well, we're going to start off with the first question, what are the main points of these readings? And the main theme that connects all the three readings in the complex is the multilayered vulnerability of migrants to infection disease. Not because of who are they, but because of the circumstances they faced before, during, and after the migration. Rather than presentation, migrants as the vectors of disease, and the audience emphasize infection risks are driven by structural inequalities such as poor access to the healthcare, unstable living conditions, and the legal barriers. And the Greenway and Castle article present the station based on the frameworks of infection disease risk, outlining how different islands emerge at different points of the migration process during transit, arrival, early settlement, and long-term settlement. And this approach reframes the issues from a static to dynamic one. Disease or risks are not fixed but change over the time depending on exposure and access to the care. An article by Cortland and Butcher, this one raised a critical point. Despite threats in the receiving countries, there is not evidence that the migrants pose a disproportionate disproportionate trends in the terms of spreading the exotic disease. In fact, the most infections are prevalent or treatable, and the real challenge is the lies in the political will, early detection, and how the inequality access to the real exchange to the lies and political will, early detection, and equal access to healthcare services. The highlight is the importance of the screening program for TB, HIV, and hepatitis and other conditions, especially when the migrants arrive from high incidence countries. And for last one, the Sanchez Montalvo article take a deep dive into the TB, showing how the prevalence among migrants is shaped by the combination of the high rates in their home countries and the situation to the due stress of pre-nutrition or the late diagnosis post-arrival. They emphasize the need to culturally sensitive access to TB programs that address not just the pathogen but also the person, their first cultural background, and social environment. Well, continue with the second question. And was anything unclear and confusing to you, and why? While the general message of the readings were clear and some contradictions and ambiguities stood out of made and they make me reflect more deeply. For example, an article by Greenway and Castle emphasizes the importance of the infection disease screening across the article. Also mentions uh, how the during Aero's large waves of migration 2015-2016, many migrants had no alarming to infection rates despite not undergoing any formal screening. And this raised a question for me. If many migrants are healthy upon arrival, how do we balance the need for the public health vigilance with the risk of systematic migrants are as carrier of disease? And another point that felt somewhat unclear and was how screening promises should be ethical implement is Colin and Butch highlight the effectiveness of the targeted screening, especially for diseases like TB and Chagas, but also hint at concerns over the cost effectiveness and fairness. And this made me wonder where's the line between pragmatic public health public policies and the potential discrimination. And how can we ensure that screening doesn't become a gatekeeping tool that denies us access to credit fair? And the Sanchez and Montalvo article also presented some conceptual tension. And one hand, it says that TB transmission from migrants to native population is minimal, yet it also emphasized the importance of identifying and treating latent infections in migrant groups to prevent the outbreaks. And this led me with questions about how to balance individual rights with population level disease control, especially when public discourses often leans toward fear and exclusion. And so while these readings were this rich information that led me reflecting on how to implement these ideas is the ways that are both effective and ethical sound and make us a better question as the future clinicals and policy makers. Okay, continue with the third question. What was new to you in the shape how you think about but all your personal things? And one of the most impactful news insights I gained from these readings was how much the stakes of migration merits understanding the health risks faced by migrants, particularly concerning infection disease. And I have always considered that migration-related health risks in a more static way, assuming that migrants were eating healthy or unhealthy upon arrival, depending largely on the country of origin. But the Greenville The Greenway and Casteller article completely transformed the view, showing how the routes are dynamic and very dependent of the whether the migrants is the transit arriving, and you'll settle or the returning to the visit to their home country. For instance, I learned that migrants are often more vulnerable to certain infections after their habits resolved, and not just because of exposure during the travel, but because the poor living conditions in the host countries allow access to healthcare on trade-laden infection like TB. Um, I was particularly surprised to read how the condition like shares or disease of the tuberculosis can go unassessed and for years, and then reactivity, especially in migrants that face socioeconomic stressors that compromise their immune systems. And this changed my perception entirely because these infection diseases are not just biological phenomenon, but are deeply social and political and actually emotional and stress is a factor. And the colon and virtue also introduced me to the concept of existentiation of migrant illness, how freedom, public anxiety often defigures a real dramatic disease, when in fact the real contrary should be more common but prevalent preventable infections. And I was shocked to learn that despite the exaggerated fears, there is not strong evidence of the widespread outbreaks caused migrants, but this forced me to think critical about how the public discourse, media, and political influence not only how the migrants are perceived, but also how the healthcare policy is designed. Okay, and continue with the first question. Was there anything you would like to explore in the further or learn more about and why? Absolutely. Reading this article raised my many important questions that I would like to explore in the further, in particular around how to design effective and ethical public health interventions for migrant populations. For example, in the Greenwood and Casale article provide a valuable overview of screening and strategic vaccination that actually used in the various countries. However, I wonder how can these interventions be adapted in to contexts where resources are limited and where political resistance to migrant health access is strong? And how do we ensure these programs don't become tools of surveillance or exclusions? One area I'm very interested in exploring the integration of community-based approaches in infectious disease, screening and prevention, and how to we build trust with migrants community that may fear disturb the formal institutions and cold community health workers from within migrants groups help bridge this gap. The idea of empowering the migrants to become the healthcare advocates within their own communities really appeals to me, not just a future doctor, but as someone who believes in the high quality services. And another issue I like to understand more deeply is the ethical tension between the public health and immigration control, and actually often delay care to the fruit of the legal repercussions that raises this important question. Should healthcare service be completely disconnected to the from immigration enforcement? And if so, how can this be forces in the practice? And how do we design systems that both protect public health and safeguard the individual rights? And technology is another frontier I'm curious about. I'm really, really curious about this one. And how with digital health tools becoming more common and that's mobile apps, health track treatment adherence, for example, for TB or for whatever this is a chronic derivative. And cool artificial intelligence or AI help train high-risk patients during early migrant stage, and these innovations could be transformative and but only one used ethically with input from the very communities that are meant to serve. Ultimately, I want to learn more about how the public health systems can be remanaged, not just to the trade of the migrants, but to include them, respecting their autonomy, protecting their rights, and recognizing their drivers' needs in this race. And continue for the last one question. Give a list of one specific example or an aspect experience in your personal or professional life that relate to the main topic. Well, during my early clinic rotations, I worked in a family health center. That's a tiny clinic that served a large number of undocumented and recently arrived migrants. And I remember a clinic case involving a young woman from Central America who came in the with a persistent fever, night sweats, and a worsening cough, and she was hesitant to speak, and the first word about it was the question with my ask. After the building some trust, she revealed that she had been experiencing these symptoms for over the 3 months, but had avoided the seeking help of cardio undocumented status might result in deportation, that actually for me is completely awesome and unbelievable because I mean, we live in Mexico, and this woman is, I I remember, I think that she's Brazilian, and it's because I guess she's speaking in Portuguese. And yeah, when we ran the test, said she was diagnosed with active tuberculosis, and it's not just a medical emergency. It's I was waiting until all the systemic follows she has in Carter, and she was living in this overcooked shelter, sharing space with a lot of person and don't have access to primary care provider, like she's no citizen. And her case reflects exactly what articles with Sanchez Montalva and Greenway describe: a situation where the social marginalization directly led to the late diagnosis and increase of the transmission and risk. And what was remarkable, however, was her care improv, and when we implemented a patient-centered approach. And this experience me taught me that clinical care cannot be separate from the social context. We can treat TB or any infection disease without addressing the housing, documentation, mental health, and trust. And it's just about antibiotics, it's about the safety, respect, and the inclusion of the patients.